What's up, Ninja Nerds? In this video today, we're talking about hypothyroidism. That's for our clinical medicine section. And if you guys have been enjoying these videos, they make sense to you, they help you, please support us. And some of the simplest ways that you guys can do that is to hit the like button, comment down in the comment section, and please subscribe. It goes a long way. Also, for your benefit, I really highly suggest this. Go down in the description box below. There's a link to our website. On our website, we have extremely amazing high-yield notes, great illustrations to follow along with, and then on top of that, if you really want to test your knowledge and understand the topic, we have nearly thousands of questions that can help you guys to understand these topics. Also, we're developing exam prep courses, so keep your eyes peeled open for things like Step 2, the PANCE, and so many more other exams. All right, let's talk about hypothyroidism. So, hypothyroidism is when a patient has very low thyroid hormone levels, but there's two types. One is called primary, meaning the thyroid gland is the problem, or secondary, meaning that the pituitary or the hypothalamus are the problem. Let's talk about primary first. We'll go over the basic pathophysiology, and then we'll go over the causes. All right, so the first thing, primary hypothyroidism, we know that the problem is the thyroid gland itself. The thyroid gland is responsible for making a hormone called T3, which is triiodothyronine, and T4, which is thyroxine. Together, collectively, they make what we refer to as the thyroid hormone. But the problem is that in hypothyroidism, they're not producing an adequate amount of thyroid hormone. So this production is reduced significantly. Now, you have to ask yourself the question, why is the thyroid hormone production reduced? Well, then you have to take and zoom in to these actual thyroid follicular cells and take a better look at them. So we'll look at them here, we'll look at them here. Now, these cells, right, if you're looking at one of these, this is a thyroid follicle. They're the actual structural and functional unit of the thyroid gland. They make the thyroid hormone. So the follicular cells, what they do is they make this black colloid here, which is called thyroglobulin. Now, thyroglobulin is like a clump of amino acids. What happens is that thyroglobulin combines with iodine. And then the iodine, when it combines with thyroglobulin, makes thyroid hormone, and it gets pushed out into the bloodstream as T3 and T4. But what if I destroy these follicular cells? Can they make thyroglobulin? No. Can they take and actually bind the thyroglobulin with iodine and make thyroid hormone? No. So the end result here is that these thyroid cells, follicular cells, won't be able to produce adequate amounts of T3 and T4. And there is a ton of causes for this one that we'll go into great detail of. The other one is interesting. So let's say that these thyroid follicular cells are intact. They're fine. But the problem is that you're supposed to take a molecule called iodine, right? And iodine, what happens is it gets taken and utilized and binds to thyroglobulin, which is those bunches of amino acids. When you take the thyroglobulin, combine it onto the actual iodine with it, you'll make thyroid hormone. And that thyroid hormone will then get released into the bloodstream. But what if I have a decreased amount of iodine? Am I going to be able to take the iodine, combine it with the thyroglobulin, and then make thyroid hormone? No. And so the problem here is that I'm not going to be able to make functional thyroid hormone. I'm not destroying the actual glands themselves, the follicular cells, but I am reducing the production. So this is the concept here. Now, big thing for iodine deficiency, this is the most common cause of hypothyroidism worldwide. So let's actually write that down. This is the most common cause worldwide. Common cause worldwide. So you want to think about this in areas where there's less iodine intake. Usually there's not enough sufficient intake, third world countries, etc. Now, let's come back a second. We know that the thyroid gland is not producing thyroid hormone because the thyroid follicles are being destroyed, or you're not having a sufficient amount of iodine to make functional thyroid hormone, right? That thyroid hormone, it goes to many different tissues. We'll talk about the downstream effects if we don't have enough of it. But what happens is, whenever the thyroid hormone levels are low or high, our hypothalamus and pituitary are supposed to respond to it. Whenever it's low, our hypothalamus and the pituitary will say, hey, we need more. Increase the actual production of very specific types of hormones. And so what happens is your hypothalamus responds and says, I'm going to make more TRH. And then I'm going to tell the pituitary to make more TSH. And this is the actual downward cascade that occurs here, is that there'll be an increase in the production of TRH and an increase in the production of TSH. So whenever you think about this, this is actually super helpful diagnostically, because primary is oftentimes remembered as having two particular things: a very low T3 and T4 and a very high TSH. And that is the very, very high yield component that I want you guys to remember. You're probably like, Zach, what about the actual TRH? We don't necessarily monitor that. These are the big things that we get from primary. All right, so primary hypothyroidism, we have the two big terms. We already covered one of them, iodine deficiency. Think about, again, iodine deficient areas, third world countries, poor iodine intake. All right, thyroid destruction, what are some causes? There is so many. When we talk about these, I want you to break them down into autoimmune causes of thyroiditis, or inflammation of the thyroid that causes destruction, infectious thyroiditis, and iatrogenic thyroid destruction. Now, when we talk about these autoimmune causes, you know your plasma cells, they make these things called antibodies. Antibodies can then actually be produced normally against pathogens, right? But sometimes we make autoantibodies that attack our own tissues. You know some of the things that they attack? Well, you know that thing I told you called thyroglobulin that's inside of the thyroid follicles? Our body can sometimes generate antibodies against the thyroglobulin. Or we'll represent this in blue. These little blue dots inside of these follicular cells is called TPO, thyroid peroxidase. We sometimes can generate antibodies against those. When you generate antibodies against this tissue, unfortunately, it creates an immune reaction and causes destruction of the thyroid follicle. What happens? You lose the ability to produce T3 and T4 because you lose the follicular cell function, right? So we have to ask ourselves the question, what are these antibodies? Well, there's three diseases that produce autoantibodies against the thyroid gland, leading to a reduction in T3 and T4. What are they? Hashimoto's is one. Postpartum and Rayleigh thyroiditis. Now, with these, Hashimoto's is by far going to be the most common cause of hypothyroidism in the United States. This one, worldwide. This one, United States. Remember that. Hashimoto's, what are the antibodies? It actually is the really important one that you remember. It makes it against both of these things that I pointed out. So you're going to have two different types. One is going to be what's called the we represent this as TG, thyroglobulin antibodies, and anti-TPO, thyroid peroxidase antibodies. These are positive in people who have Hashimoto's. Now, the question is why do we produce these antibodies? In this particular situation, they believe that it's related to young individuals who have abnormalities in their HLA genes. Like what? Well, there's very specific HLA mutations. One is this may be related to what's called the HLA DR3 mutation or the HLA DR4 mutation. Now, this is not something that you test for. What happens is that these mutations lead to alterations in immune function. And the alterations in the immune function is what leads to the undesirable production of these antibodies against our own tissues. Usually these patients will also have diabetes and maybe other types of disorders as well. So that's one big thing. Postpartum, it's literally within the name. It's a patient who's pregnant. So that one's not hard. What about the antibodies? This one, it really only has the anti-TPO. Now, the key thing that's really different here is because you're like, okay, well, how do I know it's not Hashimoto's? Well, Hashimoto's, one of the big things for this one is the hypothyroidism is permanent. You don't gain that function back. With postpartum, they do make these antibodies. And the trigger, guess what? It's pregnancy or it's postpartum. So usually within 1 year of birth of a child, this may stimulate the anti-TPO production. But the key thing is it will cause destruction, but then the actual thyroid follicle cells will regenerate and you'll gain normal thyroid function or euthyroid function back. So one of the big things to remember about postpartum is that this is what we call a transient hypothyroidism. It is a transient hypothyroidism. It is not chronic. And that is super, super important. Oftentimes, this type of like hypothyroidism exhibits a triphasic response. We'll talk about it more in hyperthyroidism, but usually you destroy the follicles, release the thyroid hormone, hyperthyroid, you destroy them so they end up going into a hypothyroid phase, and then eventually they regenerate and they go into a euthyroid state. So this is postpartum thyroiditis. And again, usually less than 1 year postpartum. So we'll put less than 1 year postpartum as the trigger here. It's some type of hormonal relationship. Which hormone? We don't know. Last one is Riedel's. Now, Riedel's thyroiditis is very interesting. It's a part of a group of diseases, and they're called the IgG4 systemic diseases. This IgG4 antibodies are produced and they cause destruction of the thyroid gland. But more particularly, they do something really interesting. What they do is they cause destruction, but it's a very interesting way. What they do is they activate fibroblasts, and fibroblasts release lots of fibrous tissue. And this leads to increased fibrosis of the thyroid gland. Look at this thing. This thing gets like super, super fibrotic. So clumps of fibrous tissue all over the thyroid gland. Now, if I replace a lot of the normal thyroid follicle tissue with fibrous tissue, I will lose thyroid function. But believe it or not, and here's what's really interesting here, these patients, maybe 30% of them will develop hypothyroidism. So it can cause fibrosis, and I think the big thing to remember here is approximately 30% will develop hypothyroidism. So that's not like a super, super large population. Now, one thing that's really important to remember here is, yes, you can see this in hypothyroidism, but the IgG4 is the giveaway. So this one is usually associated with these mutations and other autoimmune diseases. This one, pregnancy. This one, not a lot, except for a couple things. One is the IgG4 is present in other advanced systemic diseases. I would only want you to remember 3 of them though. So these IgG4s can also be present in what's called autoimmune pancreatitis. So autoimmune pancreatitis. So if they have autoimmune pancreatitis and a fibrotic thyroid gland, I want you to think about potentially what? Riedel's thyroiditis. The other one is it can cause aortitis, which is inflammation of the aorta. And the last one is it can cause fibrosis of the retroperitoneum. And so I'm going to abbreviate that RP, retroperitoneal fibrosis. All right. What is the big thing that I really want you to remember though? Because that's hard to remember, right? I can remember the IgG4 antibodies. I can remember the fibrosis. I can remember some of them get hypothyroidism. But here's the easy thing to remember. The fibrosis causes compression of nearby structures, which makes it different from other types of hypothyroidism diseases. So whenever there's this fibrosis, it compresses on 3 things nearby. So here's the compressive effect. Let's actually write that down. Let's write down. Here's our compressive effects. And the compressive effects in order is I will compress the recurrent laryngeal nerve. So I'm going to abbreviate that RLN, recurrent laryngeal nerve. If I compress that puppy, what will be the symptom? Hoarseness, right? So I'll have hoarseness. The other thing is I can compress the trachea. If I compress the trachea, I'll have difficulty being able to entrain air. So this can lead to dyspnea or it can lead to stridor. And then lastly, I can compress the esophagus, which makes it difficult for food and fluids to move down, which can lead to dysphagia, more particularly esophageal dysphagia. So if I compress these particular structures, I can see the devastating effects that a patient could experience. And so I want you to think about this in a patient with hypothyroidism and compressive effects from the actual nasty fibrosis. If you happen to remember these, try your best to remember autoimmune pancreatitis. Okay, now, 30% chance of hypothyroidism, transient hypothyroidism, permanent hypothyroidism. We come to the next one, infectious thyroiditis. This one is not super common, but it is something to be able to remember. It's usually triggered by a viral upper respiratory tract infection. So a patient experiences a viral upper respiratory tract infection. So I think one of the big things to look for here is in these patients, they may come in with low-grade fevers, muscle aches. They may come in with stiff or painful joints. They may also come in with a runny nose, congestion, sore throat. And if they also have a painful thyroid goiter, that also makes me think of de Quervain's thyroiditis. So this will be a viral upper respiratory tract infection, and it'll cause direct injury and destruction of the thyroid follicle tissue, which will drop your T3 and T4 levels. Now, with this one, the thing I want you to remember is, remember that it's going to be causing a painful thyroid. So it's a painful thyroid, and usually there's even a goiter, and we'll talk about what a goiter is in a second, but it's going to cause a painful thyroid. The other thing here is, again, look for upper respiratory tract infection symptoms. So look for viral upper respiratory tract infection symptoms. Again, headache, congestion, sore throat, fevers, myalgias, etc. And here's the kicker. This patient will also have an elevated ESR from inflammation. It's nonspecific, but it's great on your exams. So whenever you see a significantly increased erythrocyte sedimentation rate in the context of a painful thyroid and positive viral upper respiratory tract infections and hypothyroidism, think about de Quervain's thyroiditis. One big thing to remember. Remember how I told you postpartum is transient? De Quervain's is transient. This is a transient hypothyroidism. It's not permanent. That is another high yield fact. This is a part of that triphasic response I mentioned before. And again, we'll repeat that whenever we get into hyperthyroidism. All right, autoimmune, infectious, iatrogenic. These are the easiest ones. So a thyroidectomy would probably be the most obvious thing possible, right? Do I even really need to explain this? No. If a patient had a recent surgery and you cut out their thyroid because they had thyroid cancer or they had hyperthyroidism, now they don't make thyroid hormone. That is super obvious, okay? Look for a patient who has a recent history of thyroid surgery. That's all I want you guys to remember. Recent thyroid surgery. Maybe even take a look. Examine their neck. Look to see if you can actually see any evidence of a surgical scar there. The last one is a Wolff-Chaikoff effect. This one's really interesting. It's kind of weird, but it's interesting. Your thyroid follicles, what they do is they take thyroglobulin that's made by the follicular cells. When they do that, they interact with that enzyme that I told you is found inside of these follicular cells. It's a weird enzyme where it's found inside, like around the edges, and it's found inside the cells. It's called TPO. All right, so this enzyme is called TPO, thyroid peroxidase. That's the same one that you have antibodies against in Hashimoto's and postpartum. This enzyme is supposed to stimulate the conversion of thyroglobulin into thyroid hormone by adding what into it? It adds iodine into the mixture. So if iodine is added into the mixture in the presence of thyroid peroxidase, it will stimulate the formation of thyroid hormone. What if, and this is weird, what if I gave way too much iodine to a patient? I give them insanely large doses of iodine. That large doses of iodine can work via kind of a negative feedback mechanism, because what it'll do is it'll say, hey, I have lots of iodine for me to make thyroid hormone. But then your thyroid peroxidase enzyme says, oh crap, this reaction is going way too fast. I need to regulate this. And so these high levels of iodine can actually inhibit this enzyme. If you inhibit this enzyme, can you take and convert thyroglobulin into thyroid hormone now? No. Can I make thyroid hormone? No. This is called the Wolff-Chaikoff effect. It's very paradoxical, where super high levels of iodine, and what scenarios? Well, one reason is patients who take amiodarone long term. This is used in AFib, right? So chronic atrial fibrillation. That'd be one cause. Another one is radioiodine therapy. All right? So radioiodine therapy is another very common one. So if a patient received heavy amounts of radioiodine therapy or chronic amiodarone use, this can lead to the Wolff-Chaikoff effect. So this is what I want you guys to think about here. That's a ton of causes. We'll actually review a lot of this stuff when we go through the diagnostic algorithm, but this is the big thing I want you guys to know for primary hypothyroidism. Now let's talk about secondary hypothyroidism. This one's actually super straightforward, not too crazy. In this problem, it's the hypothalamus or the pituitary that's dysfunctional. So what's happening here is you're supposed to, again, make that hormone called TRH from the hypothalamus. That's supposed to tell the anterior pituitary to make TSH, right? So hypothalamus makes TRH, travels through what's called the hypophyseal portal system, which is a little vascular system between the hypothalamus and the anterior pituitary, tells the anterior pituitary to make TSH, and then TSH will go and bind on to the, what are these little suckers here called? These are called your TSH receptors, which is on your thyroid gland. And it tells it to make T3 and T4, right? Same thing, these little, if you kind of zoomed in here and looked, this is a TSH receptor. TSH will bind right here, stimulate the thyroglobulin synthesis, help with iodine, if it's there, to bind with the thyroglobulin, and then make thyroid hormone and put it into the bloodstream. But let's say I have some type of problem where there's injury to the hypothalamus. I have injury to the anterior pituitary. Now I can't make TRH. If I can't make TRH, can I make TSH? No. And if I can't make TSH, can I stimulate the TSH receptor? No. Can I make T3 and T4? No. And so because of all this, I'll have low levels of thyroid hormone inside of the bloodstream. And so the key thing here for being able to remember this is primary was this one. Secondary would be low and low, right? So for this one, I would have both low T3 and T4 and low TSH as compared to primary. So that's a very helpful diagnostic tool. Now the question comes, what's leading to this pituitary? It's primarily the pituitary, but hypothalamus or pituitary dysfunction. So I'm going to come over here and talk about the causes of pituitary dysfunction. All right. And there's two big ones that I want you guys to be able to remember. One is called a pituitary adenoma, but I want to actually be a little bit more specific. It's like a pituitary macroadenoma. This sucker is huge. Whenever you have this huge tumor, remember what I told you. TRH is produced by the hypothalamus, right? And whenever TRH is produced by the hypothalamus, it's supposed to run through the hypophyseal portal system. Well, what if, here's this little blood vessel, let's say here's a blood vessel, it's being compressed by the tumor. If it's being compressed by the tumor, is the signal of the TRH going to reach the anterior pituitary and trigger the anterior pituitary to make TSH? No. And so that's a really, really important point, is TRH may be being produced in high amounts or normal amounts, but the signal of receiving it via the portal system is being impeded. So this process here is being impeded. And because of that, TSH production is low. How do I usually think about this one? This one's really interesting. Because I have a big old sucker, a big mass right there at the pituitary, that thing pushes on a couple things. And so what happens with this is you get mass effect. And this is one of the key things that I really want you guys to think about with secondary hypothyroidism. When it compresses on things, it can lead to a headache. That's one super common effect. It can lead to compression of nearby structures and lead to a intracranial kind of presenting headache. But here's the other one, and this is the giveaway. It compresses the optic chiasma. When you compress the optic chiasma, it leads to what's called bitemporal hemianopia. This is where you lose your vision in the bilateral temporal fields. So what does bitemporal hemianopia look like? It looks like this. Whenever we have a patient who comes in with headache, bitemporal hemianopia, and again, it's important to remember why does this happen. We'll talk about it more in pituitary disorders, but a quick recap is here's an eyeball, and you guys have to remember that you have that structure here called the optic chiasma. The pituitary gland sits right here in this area. So if I have a mass that's compressing right here, I'm hitting all the fibers that are actually going to be coming from these areas here. And so that's why, is that generally this is a visual field here, this is a visual field here, and it picks up your lateral, and your lateral, it's running right through this area here. And that's why you're getting this injury here. It's because it's supposed to cross here, it's supposed to cross here, and I'm losing the visual field in my temporal fields. All right, pituitary adenoma, big one to remember. Last one here is really helpful for your boards, and I think it's because of the history. It's Sheehan syndrome. So if a patient gives birth, and from that birth, they lose a large volume of blood. So we call this postpartum hemorrhage. So the point where they've lost so much blood that they're becoming hypovolemic, they've lost more than like a liter within 24 hours, massive blood loss. In this particular scenario where they have blood loss, this can lead to very severe hypovolemia. So their blood volume will drop. If blood volume drops, what can that do to your blood pressure? It can drop your blood pressure. If you drop your blood pressure, you drop the perfusion to various tissues. And one of these areas that seems to be somewhat susceptible is the pituitary. And so the pituitary doesn't get good perfusion. If it doesn't get good perfusion, you're going to lead to necrosis of this tissue. If you cause death of this tissue, can it release particular hormones? No. And so we actually lose a ton of hormones. But in this particular example here, you'll have a reduction of TSH as being one of those big ones here. But again, you'll lose all the other hormones in response to that. So these are the two big things I want you to remember for secondary. Another one could be traumatic brain injuries, but less likely to be presented in your exams. All right. We've gone over the pathophysiology, the causes of hypothyroidism. Now I need to talk about how do these patients classically present and what's the worst case scenario for hypothyroidism. All right, my friends, now we're gonna move on to the next component here. So a patient with hypothyroidism generally would come in with multifactorial involvement. There's multi-system involvement. It's so crazy. So it's not something as simple as that you can just point to, oh, there's just one common or two common findings in hypothyroidism. There's many, because the thyroid hormone affects so many systems of the body. So whenever a patient comes in and you think that they have hypothyroidism, these are the classic findings that I want you guys to think about. Classify them in this particular manner. One is, do they have the presence of a goiter? So a goiter is kind of like an enlargement of the thyroid gland. Now let's talk about the goiter. First, the pathophysiology of how it forms, because it'll help you to understand which types of hypothyroidism present with a goiter. Now, generally, when a patient has hypothyroidism, let's say that it's because their thyroid gland is producing an inadequate amount of T3 and T4. If that's the case, if it's producing an inadequate amount, it'll then tell what? It'll tell the hypothalamus and the pituitary gland to start producing large amounts of TSH. And so whenever you produce large amounts of TSH, what it does is it goes to the actual thyroid follicles, starts triggering them to undergo replication, increase more thyroid globulin production, and because of that, the follicles get bigger and bigger and bigger. Multiple follicles make up a thyroid gland. That thing is huge. So because of that, now I'm gonna start seeing this thyroid gland get all kinds of velage. Now look at this. It's going to be a big old beefy thyroid gland as a result now. Now, enlargement of the thyroid gland. Right? You may be able to palpate this. You may be able to visibly see this. One of the big things that add on to this component here is this enlargement of the thyroid gland painful or painless? This helps with the actual differential of the cause. So painful, you want to think about infectious. This is the one that we refer to as de Quervain's thyroiditis. Now, if I said painless, this is all the autoimmune causes. So this is the one that you want to think about in patients who have what? Particularly Hashimoto's. This is a big one that I would want you guys to think about. Postpartum. And then one more. That's not a thyroiditis. Iodine deficiency. Iodine deficiency causes massive, massive goiters. So another one would be iodine deficiency. And we'll represent that with a down arrow. All right? Iodine deficiency, most common worldwide. Deficient areas across an endemic populations. Hashimoto's most common, United States. Now, painless, painful goiters really help you with being able to differentiate a little bit of the cause. Let's move into the next component here. The next one is metabolic dysfunction. Metabolic dysfunction consists of multiple parameters, but let's say here a patient is producing an inadequate amount of T3 and T4, thyroid hormone. If there's an inadequate production, this affects a couple different things. You know, multiple tissues in our body, they have a pump on them called the sodium-potassium ATPase. The sodium-potassium pump is supposed to be able to move particular ions across it. So it'll move potassium into the cell, move sodium out of the cell, right? So it helps to be able to move sodium and potassium across these cells. Problem is it requires large amounts of ATP. If I have less thyroid hormone, I inhibit the sodium-potassium pumps. If I inhibit the sodium-potassium pumps, I will then, as a result, lead to less consumption of metabolic activity. Now, if there is a reduction in metabolic activity, that leads to two problematic issues here. One is it leads to a reduction in catabolism of multiple things. Like what? Fats. It leads to a reduction in metabolism of glycogen and multiple other substances. Because of that, will I be able to break down fat? Will I be able to break down macronutrients easily? No. Because of that, these patients oftentimes gain a ton of weight. All right, so weight gain tends to be a very common feature here. All right. The other component is that these sodium-potassium ATPases, whenever you're actually helping to generate energy through these metabolic processes, you generate heat. But if you're having, holy crap, decreased metabolism of these sodium-potassium pumps, you're going to be leading to decreased heat production. So heat production will decrease. If I have decreased heat production, what will happen to my body temperature? It starts to become a little bit lower. So we refer to these patients as being what's called cold intolerant. They feel cold all the time. So if I think about weight gain and I think about cold intolerant in a patient with a goiter, I really want to be thinking about a patient who has hypothyroidism. I'm not kidding. These are super, super important ones that I need you to remember. All right, goiter, cold intolerance, weight gain. The other component here that I wouldn't say is as crucial, but think about it, especially in some kind of like minor suggestive causes or minor suggestive findings. Hypothyroidism may stimulate your posterior pituitary to make a hormone called ADH. Now, when ADH is produced in large amounts, what it does is it goes to your kidney tubules. Here you have your Bowman's capsule, PCT, loop of Henle, DCT, collecting duct, right? The collecting duct is the site of ADH. And what it'll do is it'll reabsorb tons of water. Now, when I reabsorb a lot of water, what will that do to my sodium? Well, I'll dilute down my sodium. And when I dilute down my sodium, this will lead to hyponatremia. So one of the other classic findings that you may see is a patient who has what's called hyponatremia. And it's kind of like a subcategory of what we refer to as SIADH. So hyponatremia, weight gain, cold intolerance, goiter, classic findings. What else? Whenever your thyroid is not acting correctly, it's not pumping out that T3 and T4 in an adequate amount that we should, again, basal metabolic rate for tissues, this is tissues everywhere. This includes the neurons of your brain. When you don't have thyroid hormone, the neurons aren't firing at an appropriate rate. Imagine all the neurons are slowed down, dude. It's like all my tissues are just like chilling, bro. My neurons are just chilling, bro. Same thing with the brain. So because of that, the decreased neuron activity within the central nervous system will lead to severe lethargy and fatigue. So lethargy, which is just generalized tiredness, and fatigue are very common findings. Sometimes depression's also another really big one, but that also makes sense. It's slowing everything down, dude. The other thing is that it also will affect the neuron transmission that's important with our reflexes. So you tap the tendon and you're like, man, that reflex took a crazy long amount of time because everything's gel. The delayed DTRs, or deep tendon reflexes, is super, super suggestive of hypothyroidism. So if I say delayed deep tendon reflexes, lethargy, weight gain, cold intolerance, and goiter, you're thinking hypothyroidism. All right, let's come over here and move on to the next seg. Next dysfunction here is the cardiovascular system. The thyroid hormone has a very profound effect on your cardiovascular system. So whenever there's inadequate amounts of T3 and T4, one of the big things is your thyroid hormone affects your cardiovascular system. Specifically, it works on the beta-1 receptors. You know there's beta-1 receptors that are present on the myocardium of your heart? What happens is when there's low thyroid hormone, there's less beta-1 sensitivity, beta-1 receptor sensitivity. That means whenever norepinephrine and epinephrine bind onto these receptors, they're less active, less functional. That leads to decreased conduction, which leads to a reduction in their heart rate, and also a little bit of reduction in contractility, but primarily a reduction in heart rate. So I have decreased sensitivity of the myocardium, decreased action whenever epinephrine and norepinephrine bind onto it, and a reduction in heart rate. What's that called? Bradycardia. Now, this could be present, but it's usually found in severe cases of hypothyroidism, which we'll talk about here. The other thing, which is super weird, is low levels of thyroid also control the tone of your blood vessels. Naturally, thyroid helps to maintain a balance between constriction and dilation, but whenever there's very little, constriction overpowers. And so because of that, what we'll see here is we'll see what's called an increase in vasoconstriction. You're like, oh my gosh, I'm gonna vasoconstrict my vessels. What that gonna do? Well, it's gonna cause your vessels to have more resistance to blood flow. So your systemic vascular resistance will go up. And if systemic vascular resistance goes up, your diastolic blood pressure will go up. And so sometimes in these patients, what we say is that because they're vasoconstricting a little bit too much, their resistance is going up, they may have diastolic hypertension. Now, with these, I would prefer that you remember bradycardia, all right, as the profound effect on the cardiovascular system. It can cause diastolic hypertension by vasoconstricting. One other effect, it also acts on the liver. Now what it does is it controls the uptake of LDL receptors. You see these little receptors here? These are your LDL receptors right here. What happens is less thyroid hormone means I have less LDL receptors that are going to be expressed. If I have decreased numbers of LDL receptors, will I bind the LDL in my bloodstream and bring it into the liver? No. So then what happens is this uptake becomes inhibited and LDL builds up in the blood. And so because of that, if LDL builds up in the blood, what is that disease called whenever it's super high? Hyperlipidemia. So these patients can also develop hyperlipidemia. All right, increased LDL can trigger hyperlipidemia. Now, this is the cardiac dysfunction. So if I say a patient has bradycardia, they have lethargy and fatigue, they have delayed DTRs, they have weight gain, cold intolerance, and a goiter, you think hypothyroidism. Let's add another one. This one's interesting. Usually this is helpful whenever we get into the OBGYN system, because in patients who come in and they're like, man, I can't get pregnant, or I'm having a lot of problems with my menstrual cycles, or I'm having infertility issues, libido issues, this can be something that you'll say, let me check your thyroid and make sure that's appropriate. So what happens behind this is that your thyroid gland, whenever it's not producing enough T3 and T4, this is a really interesting concept here. T3 and T4, whenever not producing an adequate amount, affect your levels of prolactin. So now my pituitary gland will start producing larger than normal levels of prolactin. Now prolactin is really a dangerous kind of guy whenever it's producing large amounts, because what it does is it alters your estrogen levels and it alters your progesterone levels. And so now, because of me altering those levels of my estrogen and progesterone, I will then experience menstrual dysfunction. And this can look a lot of different ways when I talk about like menstrual irregularity or dysfunction. This could be not having a cycle, amenorrhea, or they could have heavy bleeding, so menorrhagia. So there's a lot of dysfunction there. The other component here is they could have problems with fertility. So infertility would be another really big one. And then even libido can also be altered as well. So libido may also be reduced in women and men. All right, so reduced libido, menstrual irregularities, and infertility tend to be the kind of reproductive dysfunction. I don't want you to spend too much time worrying about those. They'll become more apparent when we talk about that in the OBGYN system. Gastrointestinal dysfunction, what about this one? Whenever there's hypothyroidism, inadequate T3 and T4, this also plays a role in metabolic activity of the smooth muscle in your GIT. So now, if I have some degree of kind of function here, all right? So T3, T4, it's supposed to affect motility. So I'm gonna have decreased smooth muscle contraction. If I have decreased smooth muscle contraction, we refer to that as decreased GI motility, or just motility. So decreased motility of the GIT. If I have decreased motility, that means that I'm not moving substances through the GI tract effectively. It's taking a longer time for them to transit. They build up, they get bulky, and now a patient can start experiencing prolonged time frames between bowel movements, referred to as constipation. And so constipation is actually a high yield one that you want to remember. So if I said that a patient has constipation, they also have bradycardia, weight gain, cold intolerance, goiter, as well as lethargy and delayed deep tendon reflexes, you really want to think about hypothyroidism. But let's add the big one in, integumentary system. Whenever a patient is producing an inadequate amount of T3 and T4, this has a really interesting effect. So what happens here, and this would only be seen in primary, this one here, only in primary. Really, most of these would be seen in primary. You can see this in secondary, but this one's really, really big in primary hypothyroidism. Low T3, T4, what does that do to your hypothalamus and the pituitary? Increase TRH and increase TSH. So now pump out more TSH. If I pump out more TSH, there is fibroblasts. And these fibroblasts heavily respond to TSH. Now what fibroblasts do is that they can produce a bunch of different types of molecules, but one of the big ones that they start to release a lot of is called GAGs. All right, they release tons and tons of these molecules called glycosaminoglycans. We're going to refer to them as GAGs though, because that's a long word and I don't know how to spell it. So GAGs, tons of glycoproteins. Now, these glycosaminoglycans, what happens is, imagine them as like water retenters. Like they love to retain tons of water. So what they'll do is they're going to retain tons and tons of water. Retention of water. But it loves to retain this water in lots of soft tissues, very specific soft tissues I may add. So there's going to be an increased retention of water in particular tissues. This retention of water causes somewhat of an edematous appearance, but it occurs in very, very interesting areas. One is right in like the tibial region, like the pre-tibial region. Honestly, it looks like a roughened orange type of appearance. And this is kind of like a non-pitting edema. All right, non-pitting, that means if you push into it, it doesn't cause the divot to stay there. So we call this one pre-tibial myxedema. This is like high yield, my friends, for particularly patients who have hypothyroidism. It can cause kind of an edematous appearance in other areas as well. It may occur around the orbits, so periorbital edema, but that's not always as specific for thyroid disorders. So you may see this in periorbital edema. And there's one other thing that it can do. I'd say it's relatively uncommon, but it's something to kind of at least think about if I mention it here, is you can get edema that occurs around the soft tissue in the carpal tunnel region. And what happens is it kind of causes so much edema that it compresses on the nerve that runs right through there, called the median nerve. And so patients can develop carpal tunnel syndrome as a result as well. So watch out for periorbital edema and carpal tunnel syndrome as potential effects of the glycosaminoglycan amounts and retention of water in the soft tissues. Other things that can happen with hypothyroidism, it also affects just the generalized texture of the skin. So they'll be having more dry skin, they'll have brittle hair and nails as well. And they may even have lots of hair loss. All right, With that being said, we have covered the classic findings. You're like, man, this is a lot. Well, we got one more. This is Myxedema Coma. Myxedema Coma is chronic hypothyroidism on steroids. And it's very specific types of classic findings that are amplified. What is Myxedema Coma? Myxedema Coma is when a patient who has, so it's kind of like a combination, if you will. It's a patient who has chronic hypothyroidism. So you'll have chronic low levels of T3 and T4, right? So chronic hypothyroidism. And an increased stress on the body. Like a massive, massive metabolic stress on the body. Now, what happens is this stressor that is occurring in these patients who have chronic hypothyroidism is very specific. What are some of these stressors? Some of these stressors could be infection. So if a patient has what's called sepsis, that can really produce a very large metabolic demand on the body. Another one is just if they had surgery. So if you had surgery, your body is kind of going into this catecholamine surge, and that could also produce a lot of stress on the body. Another one, and this one's really interesting, is if a patient has hypothermia, so they're in really cold environments, and oftentimes that's classic in the clinical vignette, is this old kind of rickety woman who was kind of caught outside in the cold weather. So hypothermia is another really, really big trigger that puts the insane amount of stress on the body. And then lastly is non-compliance with thyroid meds. We're going to put the most common thyroid med here as levothyroxine. So if a patient is either non-compliant with their levothyroxine that they're supposed to be taking for their hypothyroidism, and they say, I'm not going to take it, or if they have hypothermia, recent surgical procedure, or severe infection, this puts an insane amount of stress on the body. That stress will increase metabolic demand. So now what this is going to do is the stress will increase metabolic demand. But if you have hypothyroidism, can your body meet that metabolic demand? No. And so that's the problem, is there's so much stress, but your thyroid hormone isn't able to be produced in adequate amounts to help you to adapt to that stress. That's when this starts to happen. So what you see here as a result of this is you see a profound effect on a couple different tissues. One is you'll see the metabolic factor, insane metabolic factor here. You'll have a basic shutdown of the sodium potassium pumps. These things, done. These things are shut down. And because of that, you basically generate almost no heat. And so your heat production is significantly reduced. If it's reduced, your body has significant difficult time being able to generate heat and body temperature. These patients often present with hypothermia. This is when the body temperature gets to at least below 35 degrees Celsius. That is a super common manifestation. It's basically the decreased heat production on steroids. The other effect here is it affects the cardiovascular system. It basically shuts down the AV node. It says, all right, no beta 1 kind of sensitivity. Okay, I'm going to shut down the AV node. And because of that, I'm going to cause a massive reduction in heart rate. So these patients can have severe bradycardia. That's one feature. The other thing is it's going to reduce the sensitivity of the beta 1 receptors for contractility. And then on top of that, it's also going to squeeze the arteries. And so vasoconstriction is intense. So now because of that, imagine this. My SVR is significantly increased. If my heart rate's dropping, what does that do to my cardiac output? Drops it. If my SVR goes up, that increases my afterload. What does that do to my cardiac output? Drops it. The combined effect here will drop my cardiac output and put me into acute heart failure. So oftentimes, these patients can develop acute heart failure. And this is actually kind of terrifying. So look for a patient who is severely bradycardic with acute presenting heart failure. They may be hypotensive, they may have pulmonary edema, hypothermia, and here's the big one. Ready for the next one? Severe hypoactive encephalopathy. Their mental status is literally not even present. So they have very little firing of neurons. Because of that, these patients will have a significant encephalopathy. And it's referred to sometimes as hypoactive encephalopathy. What could that look like? They could go from being confused, they could go to being obtunded, where it's hard to arouse them. They could even go completely into a comatose state, where you can't even arouse them with painful stimuli. This is the range for the encephalopathy of a patient. So if I see hypothermia, bradycardia, and severe encephalopathy, I'm really thinking about a patient who has Myxedema Coma. And then if I add on myxedema, then I have a recipe for a patient who has likely Myxedema Coma. And what do I mean by myxedema? Usually it's pretibial, but it could be periorbital, or it could be carpal tunnel syndrome. But pretibial is oftentimes the most common manifestation. So if a patient has chronic hypothyroidism, they have a recent stressor, and now they have a comatose state, worsening myxedema, and hypothermia and bradycardia with acute heart failure, you really want to be thinking about Myxedema Coma. All right, we've covered a lot about hypothyroidism. The next part here is going into how do we diagnose it. All right, my friends, let's now move into the diagnostic approach to hypothyroidism. So when a patient comes in that you think has hypothyroidism, the first thing to do is order your TFTs, your thyroid function test. This consists of your TSH and your T4. Now, when you do this, if the TSH comes back low and the T4 comes back low, it definitely suggests a pituitary source. So with that being said, it's probably secondary hypothyroidism. I'm going to throw a little caveat in there. There is this weird disease. It's called euthyroid sick syndrome. And you usually see this in critically ill patients due to like massive cytokine release when they're very sick. The concept behind this is really looking at two things. One is if the TSH and the T4 is low, in both of these diseases, T3 will also be low. The pathophysiology of how that happens is not important, but we'll talk about it briefly. What really is the differentiating factor between these two is the reverse T3. So it's always important to obtain a T3 and to obtain a reverse T3. If the T3 is low and the reverse T3 is high, this definitely suggests euthyroid sick syndrome. The concept behind this is a little bit different in the sense that these patients are critically ill, so they degrade their TSH, they degrade their T4, and then again, they convert most of their remaining T4 to reverse T3, and they don't convert as much of their T4 to like your normal T3. So that's their mechanism. In comparison to a patient who has secondary hypothyroidism, their problem is that they, again, don't release TSH. Their thyroid gland as a response doesn't make T3 and T4. But again, the important thing to remember is the reverse T3 will not be high in a patient with secondary hypothyroidism. Now, with that being said, when you have a patient that kind of their lab suggests more of a secondary hypothyroidism picture, get a pituitary MRI. And the reason why is look for that pituitary macroadenoma that potentially could be causing this process, or pituitary infarction in the place of Sheehan, pituitary apoplexy, or maybe even the scenario of trauma and radiation. Once we've done this and we've gone down this arm, let's move down the next arm here, which is, okay, the TSH is high. That means it's a compensatory response if the T4 is low. It is. This is primary all day. In primary hypothyroidism, the concept's pretty straightforward. Again, this patient has a problem with their thyroid. They're not making T3, T4. As a response, this feedback cycle will then generate an increase in TSH to try to make more T3, T4, but it will not respond. So if that happens, I then need to say, okay, TPO, the anti-TPO and thyroglobulin antibodies. If these are elevated, it could be postpartum, it could be Hashimoto's. But the big thing to remember here is if I do that, if they come back positive consistently, I really want to think about a patient with Hashimoto's thyroiditis. The other thing to remember is that oftentimes when they're negative, it could be a bunch of other causes. How do I really determine it? You base it off their history. Did they recently give birth? Do they have any recent features of a viral upper respiratory tract infection? Do they have a painful goiter with an elevated ESR? Do they have any features of IgG4 related diseases? Autoimmune pancreatitis, retroperitoneal fibrosis, aortitis? Do they have a hard goiter with compressive effects? It could be renals. Do they have any recent amiodarone or lithium use, any recent thyroidectomy or radioiodine ablation? Have they also potentially have a deficiency in iodine? These are all things that can be obtained from the history and elucidate the cause. It's often important just to know, is it Hashimoto's or not? Now, that covers the diagnostic approach to true primary and true secondary. There is a weird purgatory, and this purgatory is when a patient has a very elevated TSH, but a normal T4. This is called subclinical hypothyroidism. The point of this is that patients can have subclinical hypothyroidism, meaning that they don't truly have a low T4, so they're not going to have a lot of the pathological effects of this. We don't really treat this until the TSH is super, super high, generally like greater than 20. So that's an important thing to be able to define here. All right, let's now move into the treatment of hypothyroidism. It's actually pretty straightforward. It's all about just giving them back the thyroid hormone that they're missing. So oftentimes for these patients, you're going to give them something called levothyroxine, also known as Synthroid. And what happens is when you give them this drug, it's hopefully going to improve their T3 and T4 levels, which will then hopefully lead to the suppression of the anterior pituitary, leading to a drop in the TSH levels. And so what you'll do is you'll check their TFTs every couple months and look to see, where's their TSH? Has it dropped down? Is it no longer high? Is it kind of improved and it's normal? Okay, great. We're in a sweet spot, and that's important. What about the patient that comes in terribly sick with bradycardia, with hypotension, with hypothermia, with maybe hypoactive encephalopathy and myxedema, and I'm terrified that they have a Myxedema Coma? I have to pump their thyroid hormone up quickly, and oral is not going to cut it. Oftentimes they need IV T4 in the form of levothyroxine and IV T3 because this is the physiological type of thyroid hormone. The other thing is that these patients will be very cold. It's important that as you give them thyroid hormone, during that process of where you're trying to get this hormone into them, you may need to warm them up with things like a bear hugger or warm blankets, potentially even warm fluids. I think the big thing to remember, especially for your exams, is when a patient comes in and you think that they could potentially have hypothyroidism that's caused Myxedema Coma, you should treat them as a patient that may also look like adrenal insufficiency. And so oftentimes these patients, you're going to give them steroids like IV hydrocortisone, and this is just going to be long enough until you actually send off their labs for adrenal insufficiency, send off their cortisol, send off their ACTH, and if that comes back with no evidence of adrenal insufficiency, you can cut the IV hydrocortisone. So that's an important thing to remember. And the only reason why is Myxedema Coma and adrenal insufficiency can sometimes present somewhat similarly. So it's important to be able to make sure that you rule that out and treat them until it's completely ruled out. All right, my friends, that's hypothyroidism. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.